Do that.
Okay, excellent. Well, hello, everyone. I'm Beth Johnston. I'm the Chief of Community Engagement here at the FSHD Society. And together here with my colleagues, Ms. Jun Kinoshita and Lucian Runko, we would like to welcome you to this month's FSHD University webinar. We are really pleased that you're here because that means you're really taking steps to becoming educated and empowered to being your own best advocate when it comes to FSHD. So thank you for doing that. Today, we are really fortunate to have a special guest with us today from the University of Rochester, physical therapist, Dr. Katie Eichinger. Dr. Eichinger will share with us some important insights that have been gained from the ReSolve study, one of the largest natural history studies of FSHD that has ever been completed to date. So my first question always is, what the heck is a natural natural history study? I don't even know what that is.
Well, let's turn that over to Dr. Eichinger, and if you want to go ahead and share your slides, that would be great. This is a good time to do it.
Okay, so yes, thank you very much for the opportunity to present some of the data from the ReSolve study. Yes, a large natural history study. So I guess I'll explain it a little bit as we go along, but a natural history study is an observational study where we look at people over time to look at how they change. And so part of this study is also to use different outcome measures to assess how people change over time. And this type of data is very important to understand kind of what happens to individuals with FSHD over time, and that can be used to help plan future clinical trials, as well as clinical care, and provide information about overall disease progression and how different individuals are affected by FSHD. So as many of you might know, the study was conducted through the FSHD Clinical Trial Research Network, which was led by Dr. Jeff Statland at the University of Kansas and Dr. Rabi Twill here at the University of Rochester. And I was the lead physical therapist for the study, so I assisted with the outcome measures and the training of the physical therapist across all of the study sites to standardize the collection of the strength and function data. So the overall goal for the study was really to help with drug development for FSHD by, again, performing a natural history study, but also by validating new clinical outcome assessments that could be used for future studies, and also to collect data that would help us to design future clinical trials. Specifically, we had different aims, and the first aim was to determine the reliability of these new clinical outcome assessments, so the FSHD composite outcome measure and impedance myography were the two outcome measures that were relatively new that needed to be assessed from a multi-site reliability and validity standpoint. We also sought to compare how these outcome measures changed in comparison to other FSHD outcomes. And then we're still working on looking at what the minimally clinically important change is. So that would be the change in these outcome measures that individuals with FSHD would report and line up with what they're reporting as change in their disease process as well. And then lastly, with all this data, we would hope to be able to use this cohort to, again, help plan for future studies by maybe helping to design for different studies, which patient populations may be best suited for certain studies. So this study followed a smaller study of 40 individuals that was conducted between the University of Rochester and Ohio State University. And we knew that to adequately prepare for clinical trials, we would need to set up a network to evaluate a standardized study protocol across multiple sites and enroll a larger cohort of participants to address our study aims. So the study participants were enrolled in the ReSolve study across 11 sites. 8 of them were here in the United States, and then 3 of them were in Europe. There is another ReSolve cohort that is continuing on in Europe. So they'll have another set of data that will be coming out that has the same protocol. But this was the original cohort for the ReSolve study. The study started in 2018 and as an 18-month study. However, after a planned interim analysis, we did extend the study to 24 months. And here on this slide, you can see the different study sites that the study was taking place at, as well as here in the United States, as well as the sites over in Europe. So Radboud University in the Netherlands, Nice in France, and then the University of Nemo in Milan. So like I said, it was a prospective 24, became a prospective 24-month longitudinal study. So the individuals that were participating in the study were individuals who were between the ages of 18 and 75, and they needed to have genetically confirmed FSHD type 1 or a clinical diagnosis of FSHD and have an affected parent or child with the disease. And then we also needed to have them have symptomatic limb weakness so that they were, their muscles were affected, but yet they were still able to walk 30 feet without the support of another person. We allowed them to use canes and braces, but no walkers. We also asked them to remain consistent with over-the-counter supplements. Individuals that were not allowed to complete the study were individuals that had medical or orthopedic conditions that would interfere with testing or give us some unclear data. Individuals that were using catabolic or anabolic agents like corticosteroids or testosterone. They couldn't be using an experimental drug in a clinical trial in the previous 30 days when they entered the study, and they weren't able to be pregnant to enter the study as well. So what did we collect? We collected across the whole person. We collected blood for biomarkers. We collected a DEXA scan, and that looked at lean muscle tissue. We used electrical impedance myography. So again, that is a newer outcome measure that I'll talk about in a bit, but that looks at the muscle composition. We collected the clinical severity scale, so the FSHD clinical scale and the clinical severity scale both kind of help us understand the impact of the disease across the entire body and how severe a person may be affected. We looked at strength using two different methodologies. We had manual muscle testing. Manual muscle testing was done across 15 bilateral muscle groups plus neck flexion and neck extension. And so that's where we push and pull. So it's probably very similar to what happens in a clinical visit. And then we also used quantitative muscle testing, which used a fixed system. So for those of you that were in the study, there was, the big frame, the force transducer, and we used straps and cables to have you push and pull against the force transducer, giving a quantitative measurement of the strength. And here we used QMT to assess 8 bilateral muscle groups. And then we also collected a bunch of different functional outcomes. So the FSHD composite outcome measure, which I'll talk about in a bit. The motor function measure, which is a multi-item measure that looks at overall mobility. The reachable workspace in collaboration with bionics. We also did pulmonary function tests to look at forced vital capacity, which is your breathing. And then the Iowa oral performance test, which looked at facial musculature. And then we also were very interested to hear from a patient-reported standpoint, looking at things like fall history, an exercise log, so that we can put that against some of the strength and function data to better understand how exercise may impact longitudinal change of FSHD. They've completed a FSHD health index, which is a measure of patient disease burden. The PROMIS 57 which is the quality of life, and then the upper extremity functional index as well, which is patient reported upper extremity function. How hard is it to lift your groceries or sweep your floor, things like that. We collected these assessments at baseline, 3 months, 12 months, 18 months, and then, like I said, the 24-month visit. We have not analyzed all of this data yet. As you can imagine, it's producing quite a bit of data. But I do hope to provide more of a high-level view of what we have learned so far. So in terms of the characteristics of the participants that were in the study, so you can see here we had a mean age of around 50, but we had a really good representation across the entire adult range, age range that's down here in the bottom corner. So we had individuals from 19 to 75, and if you remember, our inclusion criteria was 18 to 75, so almost across our entire inclusion criteria. We did notice that the European cohort, my mouse moving, the European cohort was a bit younger, although their age range was similar to the rest of the group. We had 56 participants were men, and mostly Caucasian and non-Hispanic participants, which is similar to our US and European registries. The main age at symptom onset was 25, with a mean age of diagnosis around 35. So that gives us about a combined diagnostic delay of about 10 years. But we also do note that the European cohort was diagnosed a little bit earlier than the US cohort. And then about 2/3 of individuals had a positive family history. Other characteristics, so in terms of overall effectiveness of the disease, we, if you look at the clinical severity scale and the FSHD clinical scale, you would say that these are moderately affected. So down here, you can see that the clinical severity score is 0 to 5. So the mean is 2.7, and then the FSH or the FSHD clinical score goes from 0 to 16, and you can see here again we're kind of moderately affected. We have a moderately affected cohort. Genetically, we again would say that's pretty moderately affected. So the mean D4Z4 repeat was 5.8. We did have 13% of individuals had a repeat of between 1 and 3, and then 10% had a repeat between 9 and 10. So again, genetically, based on the genetics, we'd also say that was a moderately affected cohort, with the majority of participants in that 4 to 8 range. So I guess overall, we would say the cohort has, good range of disease severity. We have the whole scope. And even though the Europeans were diagnosed a little bit earlier, all their other measures as far as genetics, clinical severity, and strength were all fairly similar. Also, in terms of genetics, there are reports in the literature that show a relationship between an early D4Z4 repeat and an earlier onset with more severe disease. And we saw a similar relationship in terms of genetics in our study and the age of diagnosis. However, it shifted just a little bit towards the older age, but we would say that, the cohort that we had in the study had to be ambulatory. So that may have taken away some of the more affected individuals at the beginning. So we looked at breathing, like I said. So this was measuring forced vital capacity. So using this machine down here or something similar to that. This data was certainly affected by the pandemic, as they didn't necessarily want us to have patient participants blowing around air and exchanging air with the pandemic. So we did lose a bit of data here. But the things that we looked at is the forced vital capacity overall was 90% predicted, which is good. We would say that it was a little bit higher in Europe at 97%, and then 86% in the United States, despite disease duration, disease severity, and manual muscle testing being similar. So we don't necessarily know why there were some differences there. And then we had only about a quarter of individuals had a FVC below 80% predicted. This starts looking at strength. So this is the distribution of lower extremity strength as assessed by manual muscle testing. And with manual muscle testing, we are really able to essentially assess all of the major muscle groups in the leg. And muscles are scored on a 10-point scale from 0 to 5. And you can see here on the right the different, medians for the different strength values. And looking at the graph overall, and this is very similar to what we've seen in previous studies, our previous natural history studies, as well as what's been reported by MRI, you can see the involvement of the pelvic girdle here on the left. And then we have knee extension right here in the middle, knee flexors, which again, we know by MRI and by clinical studies that are often affected. The ankle dorsiflexors affected. Again, this is muscle weakness that would result in foot drop. And then some individuals with plantar flexion weakness, so calf weakness, which again, we know based on MRI studies that the medial gastroc is also affected, but the calf muscle is super strong and somewhat challenging to assess. And then we can look at the same thing with the upper extremity. So here's the distribution of upper extremity strength. Again, similar to what we've seen in previous natural history studies and in MRI studies, that the shoulder girdle, shoulder muscles are here on the left. Here's the mid-arm, so your elbow flexors and extensors, often affected. And then we have wrist extension, again, knowing that is commonly, or not commonly, but can be affected, as well as the common finger extensors. But flexors are typically not so affected. And so let's switch over to functional measures. And so this is, functional measures are going to be super important for clinical trials. It's a measurement of how patients feel and function, which especially in later phase clinical trials are necessary for regulatory purposes. So the FSHD composite outcome measure was developed to measure function of individuals with FSHD specifically. So it's a disease-specific outcome measure, and is one of the newer outcome assessments that we were particularly evaluating in this multi-site study. We know that the heterogeneity of FSHD makes it really hard to just use a single item to assess function. So something like the 6-minute walk test is only going to pick up the lower body or mobility type measures, and looking at the arm function is only going to get the upper body. And so we know that FSHD affects individuals across the body and differently between people. And so it was really important to try to measure the entire body. And so what we did is take a bunch of standardized, or several different standardized clinical outcomes or standardized assessments, and combine them to form the FSHD comp. What's unique about this is that it maps to the different areas of the body that patients with FSHD report to be affected. So problems with shoulders, so this is the patient reporting information, problems with shoulders and arms, mobility, back and chest weakness. And so what we did there is look at what ways could we measure these different things, and we came up with the 18 different items to assess the entire body for people with FSHD. Each item is scored from 0 to 4, so 0 being more unaffected or normal, and then 4 being severe or unable to perform an item. And this overall score of the scale goes from 0 to 72 points. Just like the other things, we have the clinical severity scale, the genetics. We have FSHD comp scores that again reflect a nice broad spectrum of functional abilities. Here we have a median FSHD comp score of 24, so it's slightly lower than the middle, and you can see that the distribution itself is skewed to the right, and that's likely just reflecting the ambulatory inclusion criteria. So our scale captures, like I said, upper body, lower body, but individuals in the study had to be ambulatory, and I think this distribution just reflects that. But again, it's a nice broad distribution that we do see of functional abilities. So we needed to establish the reliability of performing the FSHD comp across multiple sites. We had done some initial work and reliability studies in that smaller study between Ohio State and Rochester, but we wanted to know how it was going to perform across multiple sites, as future clinical trials would likely be multi-site studies. And so to maximize reliability at the outset, we did an initial training of the physical therapist across all of the sites. And then we've had yearly training and refresher trainings to ensure that all of the physical therapists were administering the outcome measure the same way and scoring it the same way. So to evaluate this, we did do interclass correlation coefficients. These are of the raw continuous item data. So many of them are timed function tests, how fast you can perform certain tasks. And it allows us to use a interclass correlation coefficient to assess the reliability. And we did this on participants performed it on day 1 of their baseline visit and then on day 2 of their baseline visit. So it was a 2-day initial visit. You can see here that many of the items do have good ICC scores or values. So above 80 is above 0.8 is considered to be good. Above 0.9 is considered to be excellent. So we did well here. I think the one challenge we have a little bit, and I think we've gotten better at it, is trying to assess how long it takes someone to put on and take off a coat. You know, it's a little bit challenging. It comes from the physical performance test as a standardized outcome measure. But in trying to time it, it becomes a little bit more challenging, but it's a nice representative of upper body function. And so we've just kind of tried to refine it and continue to keep it into our scale. We also looked at a different statistic called the weighted kappa statistic, and I don't have the data here, but that's the scored data. So the 0 to 4, that looks at the agreement between those two scores, again, on day 1 and day 2. And again, all of those values were very good as well. The total score showed excellent interclass correlation values of 0.9. So again, really great that from day 1 to day 2, we don't notice much variation. There is a slight difference. You can see that the day 1 score here is slightly higher than the day 2 score. So you're right here. It's just a little bit lower. And you know, that could be one because of a learning effect. So people start to learn how to do some of the tests, and it's a little bit they're able to do them a little bit better. And it also could be a measure of fatigue. So in the first day of the study, they do many different measurements and assessments, whereas on the second day of the study, they only do the FSHD COM from a functional strength assessment perspective. We also wanted to understand from a validity standpoint, how does the FSHD COM, how is it associated with measures of strength and the FSHD clinical score from a measure of disease severity. So here you have the FSHD COM score on the horizontal axes. On this one on the left-hand side, it's the overall strength score. So using all of the manual muscle tests, we put them and did an average of the overall body. And so you can see here a good relationship at 0.89. A couple of things to note, and we know this, you know, clinically, is that there is more variability in individuals who are more affected, and this, you know, could be just kind of measuring or we're seeing the amazing compensatory abilities of individuals with FSHD, where they can still do a lot of physical activity or mobility activities despite having muscle weakness. It also could reflect the use of AFOs or assistive devices, again, just as compensatory strategies. The relationship here on the right-hand side is the FSHD clinical score, and the FSHD COM, again, a good relationship between the two measures, but again, a little bit more variability for individuals who are a little bit more affected. And then we also looked at individual muscle groups of the legs, and we did this for the upper body as well, but I'm just showing the leg data today. So the individual muscle groups for the leg and the different mobility measures from the FSHD COM. And what we see here is really the relationship is pretty strong with the muscles coming out of the pelvic girdle. So the hip extensors in particular have higher associations with all of the different mobility tasks from the FSHD COM. And then the other thing that's really interesting here also is that we can look at the average lower extremity strength and how it relates to the different measures of mobility. And you can see here that from an average lower extremity strength, the the best relationship is with the 10-meter walk run. And you can see that just even in the color grid, with the greens being stronger relationships, followed by the orange or yellow in more moderate relationships, and then a little bit weaker with the pinkish boxes that show a little bit lower relationship. We also looked at the FSHD COM score along some of the patient-reported data. So here on the left, we have patient-reported difficulty with arm activities for tasks of work, housework, school activities, etc. So this is like how difficulty do you have performing activities with the upper extremity. And you can see that individuals that report no difficulty is around 16 or 17, and those that report a little bit of difficulty have an FSHD COM score that's a little bit higher, around 22. And we see the similar things in the lower extremity. So here on the right, we have limitations with mobility and walking. If you look at these two categories, they're really looking at individuals that don't have, that it's not affecting their life. But once it affects their life a little bit, there's about a 5-point difference between where people don't report any challenges with it, and then where it affects their life a little bit. And lastly, super important for us to understand how the FSHD COM changes over time. Again, when we talk about longitudinal natural history studies, we want to see how, as a group, how do people change over time. We know that it's variable from person to person, but if we can get a cohort of individuals to better understand that change that's occurring across a whole a whole sample of individuals. So here we're only looking at the total score of the FSHD COM changing, but in all of the individual items where we looked at it as well, most of them were also showing change in the direction of worsening over time. And there were a couple that were a little bit more static. Things like gait speed were one of those items that didn't seem to change a lot over time. So we see, there's just a little bit of I'm thinking it's potentially learning, but there's a little bit of an improvement actually at 3 months. And then from 3 months to 24 months, you can actually see a pretty steady change, kind of slope here of the change on the FSHD COM over the 24-month period. There was a pretty significant impact of the COVID pandemic for the study. So we only had 141 individuals complete the 24-month visit. But what we did find as far as measuring change is that we have about a 2.4 point change on the FSHD COM at 24 months. You can see we extended it from, here's our 18-month data, extended it out. We, gained another point change over that year. And this equates to about a 8.5% change or worsening in function over a 2-year period. In terms of trying to use some of our information to think about how we talked about how certain people with certain characteristics may change differently than others, and what we used is a 10-meter walk run. So how fast a person could traverse 10 meters as kind of a baseline parameter. And so individuals who could perform it in less than 4 seconds really didn't change much at all. But individuals who took greater than 4 seconds or equal to 4 seconds changed a little bit more even than the whole group together. So at 2.9 points of change over that 24-month period. So next, I'm going to switch over to electrical impedance myography. So this is another one of the newer assessments that we wanted to evaluate over the course of the study. And so it's a non-invasive technique. It uses, what it's looking at is muscle composition. It has been used in other neuromuscular diseases like ALS and Duchenne muscular dystrophy. And it's thought that as muscle composition changes with changes in muscle disease, either atrophy, fibrosis, fatty infiltration, we can those changes can be reflected by electrical conductance. And so what happens is electrodes are placed on the skin, and they are used to produce and then record weak electrical currents that go across the muscle belly. And so when the composition of the muscle changes, the conduction capacities of the muscle change. And this can be measured by different parameters. So the parameters that we looked at are called resistance and reactance, as well as another parameter that is derived from the two that's called phase. Reactance and phase tend to show more differences in the muscle tissue itself, whereas the reactance tends to, or the resistance tends to be influenced a little bit more by subcutaneous fat. So just like the FSHD COM, we needed to see how this outcome measure worked across multiple sites with training. And you can see here really great data from an interclass correlation coefficient. Again, individuals performed this at baseline, that 2-day baseline visit where they did day 1 and day 2. And so this compared those 2 days of visits, and you can see that the ICCs here are almost all above 0.9, so excellent, with just a little one here just below that. And then similarly, we want to look at how the different parameters for EIM are related to strength and function. So if we could use, a non-invasive technique to kind of measure and almost be a little bit early change of strength and function, and we want to know which ones are best related. And you can see here that the phase, all of the green are the higher correlations, again, followed by the pink and then the yellow. So all of the green really kind of fall in that phase parameter. And we're looking at the FSHD COM, the motor function, the clinical severity score, the clinical score, the average strength score is tested by manual muscle testing, and then by the quantitative muscle group testing. Again, you can see the average manual muscle testing score. We get really a comprehensive look of the entire body with those muscles tested. And then again, with the mobility measures, again, just the 6-minute walk test, the 10-meter walk run, and the timed up and go, all again having good relationships with the phase parameter, whereas reactance had a little bit less. I mean, still some or many of them were still significant, but not as strong of correlations with the different measures. And then same thing here, we want to know how does this change over time. And again, you can see that the phase parameters demonstrate significant changes over time we looked at the 24-month period, and you can pick up change at the 24-month period with these different parameters. Whereas again, with the reactance, not so much. The changes weren't considered to be significant. And then the reachable workspace. So this is another clinical outcome assessment that we evaluated participants with in the ReSolve study. And we did this in collaboration with Bionics, so Dr. Jay Hahn and Maya Hatch and their team that developed this measure. So reachable workspace is a outcome measure that assesses a person's ability, their reaching ability, how far their arm can reach. And it's a task that many individuals with FSHD report as being affected. And so important to participants' daily lives. What it does is it uses a 3D motion capture system. So it's the Microsoft Kinect, and it uses a video guided protocol. So individuals are instructed to move their arm in different planes with a video that plays along with it. It's here on the left-hand side. And they're mimicking the movements of the person on the video. And what we get once this data is all processed using algorithms, you get the different quadrants of reachable workspace and a total score of how much an individual can reach. So we really work led by Dr. Leo Wang and Maya Hatch. They looked at the reachable workspace and the clinical severity score. So here you can see that again, I kind of mapped it down here of the different quadrants. So this is for the right arm only. So this is the right arm reaching across the body to quadrant 1, the upper body, and then the lower reaching across the body of quadrant 2. And then the same side is going to be quadrant 3 and quadrant 4. And then this is those same colors are placed here where individuals can reach against the clinical severity score. And so you can see here that individuals who are less affected are able to get to that quadrant 1 based on their clinical severity score, versus individuals who are more affected with a clinical severity score of 9, who really have very little ability to reach 1 above their head. They really are just reaching below their shoulders on the medial side as well as the lateral side. And then the overall reachable workspace, so the total is represented by the actual height of all of the different quadrants put together. And they also looked at the relationship of the reachable workspace to strength and function. So here on the left-hand side, we have the different strength measurements. So the vertical axis is the % predicted quantitative muscle testing. So it takes the raw value from that fixed muscle testing system. It compares it to individuals of the same sex, the same height, and the same gender. And we are able to come up with a % predicted score. So that's just another way of looking at strength. And they looked at strength here, and then this is the left arm in the light blue, and then the right arm in the dark blue. And then for those of you who've done the protocol, this is with without weight. So we asked them to perform it once through with the weight, but without a weight, and then once through with a 500 gram weight on their wrist. And so then the bottom one is with the weight. Okay, and again, you can see good relationships between strength and the reachable workspace. And then over here on the right, same thing. Now we have the reachable workspace again on the horizontal axis, and we have the upper extremity functional index. So this is the patient's report of being able to perform daily tasks and how difficult daily tasks are using their upper extremities. And so we're comparing upper extremity functional index against the reachable workspace. And again, you can see good relationships here. And we are still working on the longitudinal data for the reachable workspace. And I should also mention that the electrical impedance myography has really been led by Carleen Mull at Radboud University and Dr. Mike McDermott to look at all of that data as well. So I think, so in general, the overall conclusions for our study is we have a nice study that included a cohort of individuals that were across 4 different countries, many different states as well within the US. We have a broad range of age, and we have a broad range of disease severity. That's going to give us the cohort to help us understand which characteristics may be predictive of different amounts of change over time, and again help us to define what individuals would be best suited for certain clinical trials. We also found that our training worked. We did, like I said, the multi-site training of all the physical therapists and the individuals, the physicians typically doing the EIM data collection, and we were able to get reliable data across multiple sites, which is, again, is really important to know going forward for multi-site clinical trials. We were able to describe them in natural history. So how much did individuals change over time? Looking at the different clinical outcome assessments, and we'll be looking at the patient-reported measures as well. And these individuals were affected, but they were still ambulatory. So again, just kind of putting that along, what this cohort looks like. And like I said, there's a lot of data, and we still are working through it all. We need to look at, do genetics or different disease characteristics or different personal characteristics like age, gender, or the baseline functional status predict how a person's going to change over time. We have data looking at pain, and like I said earlier, the exercise. So what effects do pain and exercise have on how people change over time. And we also need to look at what I said at the beginning, the clinical meaningful changes. How much change do we see in our outcome measures? And what does the patient report as change? And how are we able to determine how much change on a clinical outcome assessment is able to be reported by a patient participant as well. Certainly, would not have been able to do this without all of the FSHD participants and their family members, again, over a pandemic for a lot of the study. And so we certainly appreciate, lots of efforts from a lot of people. Certainly our funding agencies, including the FSH Society. Lead PIs, Dr. Jeff Statlin and Ruby Tuwell. Michaela Walker, most recently, has been the project manager. And Leanne Lewis is the lead coordinator, and Mike McDermott is our biostatistician. And then certainly all of the PIs, the study teams, including all of the research coordinators and physical therapists across all of the 11 sites where we've been able to really hang on and have steady study teams participating in the FSHD clinical trial research network, as well as this study in particular. And I think that's all I have, and I'd be happy to take questions.
Thank you so much. It was just, it's an epic study when you think of the sites and the numbers of investigators and the individuals who participated over this period of time. So I just am in awe of everybody who was involved.
Huge team effort from everyone, from the participants to the teams and to the funding agencies. It really took a big team to do all of this work.
Yeah, no, great. Do you want to unshare your slides and then we can go into kind of the Hollywood Squares mode here?
That sounds great.
And everybody else who's at Beth, Lucienne, you can come back too if you want. So everybody, use the Q&A section to post questions. And now I see we already have a number of things here. The first one is actually Bill Lewis says I borrowed the EIM device at UC Davis and tested my quad before and after doing yard work. There was a drop in impedance, and he was thinking EIM could be used in an acute exercise study. Do you know if anybody's thinking along those lines, doing other studies with EIM?
I personally don't know if that's being done in that way. I'm also just wondering if some of that can be influenced by other factors in the muscle, water in the muscle and things like that could maybe have some influence over that. But I don't know if it's been used for short-term kind of investigational studies. I would have to look around.
I think commercially, EIM, the device is used by people doing physical training and things like that, just to.
Can I ask a follow-up before you move on to that? So there's going to be an exercise study that I've understood from the CTRN. Will they include something like EIM in an exercise study? Are you aware of that, Katie? Or
I am not personally aware of that, but I can definitely do some investigation.
Okay, thank you.
So Sylvie asks, according to your results, would you say that a duration of 24 months is necessary and or sufficient for a clinical trial to assess the effects of a treatment?
Well, certainly, I think our industry partners don't really want to see a 24-month study. So that's considered a really long study. What we don't know is, so what we were measuring here was disease progression. And we don't know if you have an intervention of sorts, either rehab intervention or pharmaceutical intervention, how the FSHD-COM in particular, I guess I would speak towards that, how that would change over time, because really now you're looking at an intervention study versus a natural history study. And so we don't know if we're looking to slow progression, what would that take? And we can look at different sample sizes that based on our data that might help to shorten a study. But again, we don't really know specifically how long a study would need to be to show a change where it may be not so much just slowing disease progression, but showing some sort of improvement. The other thing that we oh, I just lost my train of thought. Oh, it'll come back to me.
While you're looking
Yes.
at there's a kind of a related question, I think, tying the data you showed to some of the clinical trials that are being conducted. So are they using the measurements that you are finding to be most sort of sensitive to change?
So let me go back, and the other thing that I was thinking about before is also thinking about different measures and different phase studies. So in our study, where we're looking at clinical outcome assessments that are going to be most important to probably phase 3 studies, they may be used in earlier phase studies, but it's really at the point where we're looking at regulatory approval that you need those functional measures. So there are other pieces of our study looking at biomarkers and things like that that may change earlier and be able to look at for earlier phase studies have changes in those measures versus the clinical outcome assessments. In terms of other studies, the reachable workspace has been used in studies, the FSHD has been used in studies, pieces of it have been used in studies. So I think that's just my little knowledge of what's happening across the field. I think there's other outcome measures that are also being assessed in other studies too. So I hope as a field, we'll continue to work towards finding what the optimal measures are to be able to use them in clinical trials.
June, may I ask another follow-up
Lucienne.
question of Katie? Katie,
Of
I so
course.
much appreciate you answering our questions. I wondered if it looked like some of the assessments had maybe more variability than others, and some may have changed more slowly than others. So if you remove those that had the most variability or the slowest change, what's the most rapid change you can get over time that appeared clinically meaningful? Do we have you analyzed the data across all of the different components of the COM in that way?
We are working at it. I'm meeting with Dr. Mike McDermott tomorrow, and we're really hoping to kind of finalize some of that. I think, again, just kind of even trimming out some of the cohorts and, again, looking at some of those initial predictors. And we can use the data from the relationships between, like I said, the EIM measures, the FSHD and how it's related to strength and disease severity. And so maybe we trim those cohorts down to individuals who are less variable. And typically I think we see that individuals who are more affected are a little bit more variable. And again, I said that's because of, their amazing ability to compensate and do things in ways that we aren't anticipating to measure. So so we may be, looking at smaller cohorts, and we don't have huge numbers to break it down into smaller cohorts, but we will try to look at it similarly to what we did with the 10-meter walk run and look at, do certain individuals change more than others?
Right.
That data is coming very soon.
It's so exciting. I can't wait for the data. The upper extremity function looked like it was pretty variable compared to other things. Is that your sense of it? Or
in terms of what?
there was a larger spread relative to strength than when you compared the run walk to strength. Just for instance, you had those both on one slide, I thought. Maybe I misinterpreted that. That's okay.
Okay.
Well, let's see. We have a question from Ricardo. He says, will this data be made available to researchers? So I assume he means the raw data for additional analysis.
Yeah.
And related to that, somebody was asking, what about AI?
So all of the above, yes. So I think there's been some projects trying to work on looking at it using AI, and also, yes, it will be publicly available once we I think actually some of it is, but once we will do our analysis and publish that as well.
Yeah, they were very generous, and they've actually given the raw data to individual companies to analyze to help them make decisions on what would be used in their studies. So they've been remarkable.
Yeah. Okay, so actually follow up on Ricardo. I was wondering if these parameters, I guess all the data that you're collecting or collected in ReSolve could be included in registries in other countries in order to get more data. That, I mean, that is a very daunting amount of stuff to put in a registry questionnaire, but I guess maybe a way to think about is, are there things that popped out that you think should be added to a standard registry like data set that currently are not?
I think we're learning, and we're learning about what we're learning about more specific things that that cross over between patient-reported outcome measures and what we see in the clinic. And I think if we can use those relationships and have registry data or other patient-reported data forms kind of tied to what we know clinically, it may be able to, we may be able to use the clinical register or the registries to gather more information from people who live across the world.
And there's a question from someone who participated. I don't know if it's ReSolve or Move. It's in Ottawa, Canada. I don't know off the top of my head, but he mentioned reachable workspace. He's wondering if the study can be continued. And I guess the same could be asked of any natural history study. They're funded for a certain period of time. You kind of figure out, right, what's the length of time and the number of participants that will give you power that study. But you know, we have people who are eager to continue.
and which is so appreciative for sure. But what we do have is a slightly different protocol that's taken, you know, we're trying to make it a little bit less not rigorous, but less involved, because this was a major long study visit for individuals. So we've tried to trim it down a little bit. And that is the MOVE study. And so individuals, and we are tracking the data from individuals who participated in ReSolve and have gone on to the MOVE study to be able to get a little bit longer longitudinal data. And so the MOVE and the MOVE Plus study is being conducted again by the FSHD CTRN. And so looking at those study sites and being able to continue on. And I do think Ottawa is one of them, but I don't quote me on that.
Okay, well, so check it out. We'll definitely MOVE and MOVE Plus are looking for more participants. So yep. Here's an interesting question. Is methylation of the D4Z4 region being analyzed and part of the study analysis?
Yeah, it is. I just, you know, not included in my data sets quite yet.
Is that forthcoming? I guess. Yes. And let's see. There are a number of questions that are wondering if the impact of like physical therapy, massage, exercise, pain levels, etc., are those being collected as part of this data set to look at their impact?
So yes, so we have pain for sure. We have exercise for sure. Individuals were asked to keep an exercise log. So we will be able to include that in our analysis to be looking at do those things have an impact on how individuals change over time.
Okay. A couple people are wondering, they felt or thought that FSHD is considered kind of to have a stepwise progression, at least at the level of the individual. They experience like a sudden change and then might plateau for a bit and then another. But the data seem to show more of a linear, less of a stepwise progression. Can you comment on that?
Yeah, so I guess what I would say is it's the complete cohort of individuals that we're looking at that gives us that linear progression. So individuals will be changing as what we understand and what we think happens is that different individuals change at different rates and different muscle groups change at different rates. And, you know, I know that I have participants who, you know, don't change over years. And then I have other participants that change in 6 months. And so when we put all of that data together, we're getting that linear change. but it may be different from individual to individual.
Well, at the individual level, do you have a sense, and maybe the study doesn't show, but you have extensive experience working with individuals as a physical therapist and evaluator. Do you have a sense of that there are these jumps that occur and what might precipitate those sudden changes in function?
We used to, I guess I would say, we don't know the answer to that fully. I would say that, you know, we did kind of think of that stepwise change. And so we would think that, you know, strength is kind of continually changing, but there is, so the strength curve is usually pretty smooth and linear. But what happens is different functional levels require a certain amount of strength to complete. And so that's where we kind of thought about this stepwise fashion of change with individuals, is that, you know, function changes for a little while and then they go along steady, and then they hit another tipping point where the function changes again, and then again it goes steady for a little bit. And maybe overall that is continuing what happens. But I would also say that we do still see variability in that. And we, like I said, I can see an individual come in and note significant change in a short period of time, and others who are very static, and we don't fully understand why that heterogeneity exists.
There's a question regarding if you look at the participants who are over 65, and you have natural kind of loss of strength with aging, did you see if there was a way to correct for that or separate out the aging related, I guess, effect versus the FSHD?
Yeah, I would
effect?
hope that we could see, again, the subgroup may be too small to really understand that, but I do think that it's important to look at, because what I would suggest that we look at there is really truly the exercise piece, because we know that our muscles change as we age. And so you're getting age-related strength loss on top of disease-related strength loss, and we know exercise can combat the age-related strength loss. So if we can try to tease that out using our exercise log, again, depending on how many individuals fall in that category, we may have you know, some inkling of kind of what's happening in that older age group.
Mm-hmm. I think related to that, someone was wondering if the variance that you see in upper extremity might be related to the lack of daily use or exercise of those muscles. And I note that in the care guideline, we're using like close to half of people, almost a majority of patients have scapular involvement or upper body weakness, and only half of them do any kind of physical therapy, fewer than half. And so that would be interesting to see if people who exercise versus don't in the upper extremities have
if there's a change.
differences. Yeah. Well, hopefully we'll see something of that with the when you analyze the exercise logs. That'll be great. We're almost, well, we are out of time, but we have a question here. Was there anything that surprised you or was unexpected out of this study?
I think part of it is we didn't fully know. You know, we had some idea of nothing had ever been studied for this length of time, and so we had our single site study was just about a year, and so we knew kind of what that changed. And when we went to 18 months, we knew that we had to do an interim analysis to look to see if we had to go further and longer to better understand that change. And so I think we did that because we just really didn't know at this point. I think we got good validation of the muscle groups that are often affected, how strength and function are related. So I think there was a lot of things that we knew about from smaller studies and from MRI studies, but I think this really helped us to understand how things change over time and what things don't change over time, and how do we use that information just as much. I think you know, we've used a lot of we've thought a lot about the people that fall in that moderate group, but I think also we may have some clues in the more extreme groups. So the people who are or more affected and how they change, and the individuals who are less affected and how they change. I think that may give us a little bit more information about overall the impact of FSHD and how it changes overall.
Okay, great. And before I turn things over to Beth for final closing remarks, there were a number of questions relating to the ongoing Avidity clinical trial and other trials. And if you have questions about enrolling in them, contact the FSHD Navigator. There's a link. Actually, I don't know, Beth, if you have offhand their number or their link, but that's a program of the FSHD Society that will help you help answer the questions that are very specific to yourself and you're wanting to connect with a clinical trial. So with that, Beth,
Yes.
all yours.
Well, I'd just like to thank everyone for joining us today. Special thank you to Dr. Katie Eichinger for this super interesting and informative presentation, for answering all of our billions of questions. But most of all, honestly, Dr. Eichinger, for all the work that you're doing for FSHD community. We appreciate you and love you so very much. So thank you so much for everything that you do. Our next FSHD University webinar is Thursday, December the 19th. Our guest speaker is Dr. Nick Johnson, who was part of this study as well from VCU, Virginia Commonwealth University. He's actually going to present our annual FSHD drug development update, which is culmination of everything that's happened all this year. So it should be very interesting. Just be sure to visit our website, events calendar for all the upcoming chapter, wellness, educational events. And thank you again for joining us today, and we will see you next time. Take care, everybody. Happy Thanksgiving.
Thank you.
Bye.
Happy Thanksgiving.